As I said, welcome everybody. This Daffodil Centre research webinar series on implementation of equitable care across the cancer continuum. At the outset, I'd like to start by acknowledging the country that the Daffodil Centre founding institutions, the University of Sydney and the Cancer Council New South Wales, are built on, and to acknowledge the traditional custodians of the unceded lands we're all joining from today. For me, that's the Gadigal people of the Eora Nation. And I'd also like to pay my respects to elders past and present and extend that acknowledgement and respect to any Aboriginal or Torres Strait Islander people who might be present today. I really hope that this webinar honours the community-minded spirit of our First Nations people and their commitment to sharing knowledge for the benefit of all. Just a couple of housekeeping matters to start with. Unfortunately, you're all in listen-only mode, which means that we can't see or hear you. However, we do want to hear from you. We welcome questions throughout the presentations, which you can type at any time into the Q&A button on your dashboard, and we'll endeavour to answer those questions in the panel discussion that we have at the end of all of the presentations. Just letting you all know, this webinar is being recorded and will subsequently be uploaded to the Daffodil Centre YouTube channel, so you and any of your colleagues who might have missed this can watch it at a later stage. And one final thing, which is to note that there should a short survey should pop up at the end of the webinar. Should only take a minute or two to complete, but we'd really appreciate your feedback on what you thought about the webinar and what we can do to improve things next time. So before we get started, just a couple of notes about the Daffodil Centre for those of you unfamiliar with it. It's a research partnership between Cancer Council New South Wales and the University of Sydney. It was launched in 2021 to bring together the strengths of both institutions to create a greater impact in cancer control. And our goal is to support policymakers, clinicians and cancer control agencies to make evidence-based decisions across the cancer control continuum and to generate the greatest impact at the population level. And this webinar series is an initiative to bring together experts in the field of cancer control to discuss important issues at a local, national and international level. And I'm really delighted or excited to have the opportunity to bring together 3 early career researchers who are really leading the way towards implementation of equitable care across the cancer continuum. So our 3 guests today are Dr. Ashfaq Chauhan, who's a research fellow at the Australian Institute of Health Innovation at Macquarie University, Dr. Nicola Creagh, or sorry, soon to be Dr. Nicola Creagh, a research fellow at the University of Sydney in the School of Health Sciences, and Dr. Verena who's a research fellow here at the Daffodil Centre. And I'm really excited that we've got these 3 incredible early career researchers here to share their work and share how they've applied an equity lens to implementation, to conduct research with important implications for implementation of equitable cancer care. So without further ado, I'd like to introduce our first presenter, Dr. Ashfaq Chauhan, who will share his slides. Thanks, Ash.
Thanks, Ben, and I hope you all can see my slides over here. I can't see you, so just Ben, can you just let me know if you can see the slides?
Yeah,
excellent. Thank you.
Thanks, Ash.
Thank you, everyone, and thanks, Ben, for the opportunity for allowing us to present on some of the topics and some of the work that I have been conducting as part of the team that I'm working with at Australian Institute of Health Innovation. So today I will be talking about engaging with culturally and linguistically diverse communities in cancer services research. What I have learned as part of my PhD and a postdoc project that I was working on, and what are the next steps for me as my postdoc is coming, the project that I was working on is coming to an end. Uh, so before we start as well, I would like to acknowledge the traditional custodians of the various lands from which we are all coming to this webinar today, and pay my respects to all First Nations people joining us today here in this meeting, and the elders past, present, and emerging. So schedule-wise, I will talk briefly about uh, consumer engagement in co-design research through co-facilitation. So focusing on one element of engagement of people from culturally and linguistically diverse background in the research cycle. Um, then I will briefly touch upon one of the projects or the postdoc project that I'm working on at the moment in which we have used the implementation science framework to improve uptake of advanced care planning, and then some learning lessons and the next steps with panel afterwards. So the main goal across the Can Engage project, within which my PhD was embedded, and the iCare Can Plan project, which was my postdoc project. These two projects were led by Professor Rima Harrison, and the main goal across these two projects was to make cancer services responsive to the diverse needs of the populations they serve. For Can Engage project, it was in the context of improving safety of people from culturally and linguistically diverse backgrounds accessing cancer care. And I Can Care Plan project was improving uptake of advanced care planning among people from culturally and linguistically diverse backgrounds. And in both of these projects, we used co-design to develop interventions, respectively, to then and implement those interventions. So within our use of co-design across these two projects within cancer research was in the context of community-based participatory research framework, or the method, an approach which has been established since over 30 years. We use co-design within CBPR, or the community-based participatory research framework, to enable us to develop and deliver programs and resources that seek to reduce inequities in cancer care for people from culturally and linguistically diverse backgrounds. Within using this framework, using the co-design embedded within this framework or adopted this framework, we have used a number of resources, some of which I have posted pictures on the left-hand side of the screen to improve cancer services for people from CAL backgrounds. So this cycle is not unfamiliar to many of you, and it's a common practice now when we talk about consumer engagement in a research cycle or a project cycle. But I think the key consideration is the inclusive and meaningful engagement across the research program of work through various mechanisms. Across both Can Engage and I Can Care Plan project, people from culturally and linguistically diverse backgrounds were involved in inception of ideas at the start of the project conception, contributed as an AI or research partners during the grant application processes, and participated as consumer advisory group members or project steering group members to providing a consumer lens throughout the project cycle, bringing that consumer experience, and participated as consumer co-facilitators in the co-design processes, developing co-produced interventions and producing research outputs, such as manuscripts and presentations. And I think today I will focus on one element of this, which is the consumer co-facilitators, or involving consumers in co-design. So we know that the co-design is challenging in the context of ensuring equity and power balance, especially for people who are from priority population groups, such as those who are from culturally and linguistic diverse backgrounds, because of cultural and linguistic differences, and or those who have a disability, etc., from an access point of view as well. Often co-design are led by health services researchers in the context of health research programs, or clinicians in the context of quality improvement project. And when consumers are not involved or less involved in the co-design processes, there can be power imbalance in how then co-design occurs with consumer members who are participating in the co-design, and also in priority setting in terms of what needs to happen or what should the outcome be or what is the priority of the co-design. One way to mitigate this power imbalance and priority setting is involving consumers as co-facilitators in the co-design process. And we kind of highlight three approaches or three kind of mechanisms where consumers can be involved as co-facilitators in the co-design process. And those three approaches you can see are on the image on the right-hand side of the slide. So the approach one is where the planning and facilitation occurs so both consumer and research co-facilitators work together to design, plan, and execute the workshops in a dynamic and collaborative process. In approach two, one co-facilitator, either it could be a consumer co-facilitator or it could be a research co-facilitator or a clinician co-facilitator as they feel comfortable, takes the lead and the others support that role as a supportive co-facilitator. And the second approach is more suited in the context of when there is a complex co-design process or complex co-design activities where an expertise may be required to conduct those activities or co-design processes. The third approach is where the facilitators take turn in or alternating leading roles in how to conduct the activities or the co-design, and each may plan a section of the session or lead the element of the session supported by the other co-facilitator. And in our experience, or in my experience of in developing interventions with consumer co-facilitators or conducting co-design with the consumer co-facilitators, oftentimes it can be these three approaches are combined and needs to be agreed upon, I suppose, at the start of the co-design. So these approaches often occur as a continuum where one approach kind of blends into the other one during the co-design process or co-design workshops. So now, what are some of the guiding principles of for co-facilitation in co-design? So we proposed these 10 guiding principles of involving consumer co-facilitators in co-design, and more can be found about these guiding principles in the link, not the link, but the citation which is listed below at the slide. But I will talk a couple of them. So relationship establishment refers to acknowledging the expertise, the reflective practice, and the lived experience as well, and understanding what financial support consumer co-facilitator may need. And role definition and distinction refers to clearly defining what is the role of the co-facilitator in the process and what is the role of the other members. And we often use terms of reference or co-facilitation guide. So we develop these documents that clearly outline what are the role definitions and distinctions, and that kind of sets in expectations as well. And those terms of reference kind of helps as a reference point to come back to if people have any issues or if people have any questions about the definitions or any other processes that were discussed beforehand. The other thing which I want to highlight is about the communication signals. So when co-design workshops happen, they are often 2 hours, 2.5 hours workshops. And when co-facilitators are interchanging in between conducting one element of the co-design workshop or one to another element, then having some established mechanisms how the consumer co-facilitators and research co-facilitators can communicate is useful, and it kind of helps towards building confidence of consumer co-facilitators. Often we have used sticky notes as a mechanism or hand gestures or something very similar to that in terms of as a communication signals between co-facilitators during workshops. And I think you can find out more about these principles, as I said, in the citation listed below. Now, I would like
Good morning, everyone. I am Ashrika.
Sorry. What I would like to do now, I would like for you to hear from one of our consumer co-facilitator who helped us with co-design of co-designing slides that are now being used at cancer services in Southwestern Sydney Local Health District.
Good morning, everyone. I am Ashrika, a consumer co-facilitator in the Can Engage Research Project. I work closely with clinicians across every stage of the co-design process, from planning and shaping workshop activities to co-facilitating the session themselves. One of the biggest achievements was that consumer voices were not just heard, they shaped the process. By bringing lived experience, we ensured the content was grounded in real-world needs, making the outcomes more inclusive, relevant, and meaningful for diverse communities. This collaborative approach directly contributed to the success of our co-design workshop. We also focused on creating equal participation. Activities were structured so that everyone, regardless of background, had a chance to contribute. We listened deeply, made sure all voices were respected. This created a strong sense of trust as well as creating inclusive and collaborative environment. Flexibility in my role also made a big difference. Being able to contribute in ways that matched my strengths made me feel valued and supported. It built my confidence and helped build team relationships, allowing us to work more effectively together as co-design partners. Peer role was one of the keys to success. As a consumer co-facilitator, one of the most important parts of my role was acting as a peer, someone with lived experience who could connect with other consumers in a more informal and relatable ways. Peer-led engagement made a big difference. When participants saw someone like them in a co-facilitation role, it helped them feel more comfortable and safer to speak up. During breaks or group activities, I often had informal conversations that helped participants feel supported and included. This peer support helped boost their confidence and encourage more open and honest contribution. By building trust in this informal way, we are able to make the consumer voice stronger and ensure more equal participation.
So before I go into the next part of the presentation, I would just like to say that what Mashrika mentioned there in the context of consumer co-facilitators being an essential element to build that relationship with people from culturally and linguistically diverse backgrounds who are contributing to co-design was very important. And we have continued involving consumer co-facilitators as an essential part of our co-design, developing co-design interventions. So now I'm going to talk a little bit more about I Can Care Plan project. So this project was funded by Cancer Institute New South Wales as a career development fellowship awarded to Professor Ima Harrison, who is my supervisor/manager. And this project came to an end in June this year. There are some elements which are progressing slowly from this, progressing on from this project, and I will touch upon that. So the main aim of the I Can Care Plan project was to improve uptake of advanced care planning among people from culturally and linguistically diverse backgrounds affected by cancer. This was in the context of evidence that the people from CAL backgrounds often have poor engagement and poor uptake of advanced care planning. And so this project adopted a sequential study, had 4 main objectives, and we addressed those 4 main objectives through these 5 different studies. We conducted a retrospective medical record review. We conducted a large cohort study of 56,000 medical records, of over 56,000 medical records in one state in Australia, to look at the presence of advanced care planning. And this was a data linkage study. And that study showed that the people who are from culturally and linguistically diverse background with cancer the likelihood of them having an ACP documentation or any ACP documentation was 60% lower than people from general background. We are also conducting as part of that as part of that third objective to see to also understand within the New South Wales what is the landscape. So we have analyzed about 120 medical records at one site, and from those medical records, it has become evident that people who are from CAL backgrounds often have poor outcomes or poor end-of-life care in the context of uh, uh, quality of end-of-life care. So there have been more people who have recorded their death being in acute care hospital as compared to those say in palliative care or in hospice center. So this is the work in progress we are continuing at the moment. But I want to focus mainly on the second objective, which was to look at the barriers and facilitators of advanced care planning or implementing advanced care planning with people from CAL backgrounds. And this study was conducted using theoretical domains framework. So we conducted focus groups and 3 interviews with 31 healthcare staff providing care to people from CAL backgrounds who had cancer, and interpreters who are involved in ACP discussions nationally. And we developed the question guide using the TDF framework to understand the factors within the domains of the TDF to understand how these factors influence the implementation of ACP with people from culturally and linguistically diverse backgrounds. We then use that framework to conduct a framework analysis within the TDF framework to conduct the framework analysis. So we did the inductive analysis first, inductive thematic analysis first, and then mapped the themes against the elements of the framework. And what we found, as you can see on the image on the right-hand side of the screen, there were various factors related to the skills, knowledge of the cultural factors, availability of resources and support to conduct ACP, as well as the environmental factors, such as where the ACP discussion occurred. But what we identified through this study, that how clinicians and interpreters work together when conducting this communication with people from CAL backgrounds was really important. It was identified as a key underlying issue across the 4 themes, and it was identified that there is a poor interprofessional collaboration, and there were very limited opportunities available at service level, such as there was, for example, briefing or debriefing were recommended, but not always the norms. People often learned how to communicate or involve interpreters in ACP on job as a tacit learning experience rather than coming prepared with it. So we took this finding and then we conducted co-design we conducted co-design workshops based on those findings from the qualitative study to co-design an intervention to improve interprofessional collaboration between clinicians and interpreters in ACP communication. And we involved a range of different stakeholders. So we had people from CAL backgrounds who had experience of conducting ACP discussion. We had interpreters, we had interpreter services managers, both at state level, at government level, and also those who were running the private interpreter services. We also had external stakeholders who had implemented something very similar in their setting to understand what were the important factors from their point of view in relation to implementing the co-design intervention so that the collaboration could be improved. So we conducted, this is just the overarching structure of the co-design workshops. So we conducted 3 co-design workshops. Each co-design had their own distinct aim leading up to the development of the program. So the first one to agree on the scope, that this is the scope of the co-design. Second workshop was aimed around to co-design the solution. And the third workshop aim was to develop the content and the implementation strategy for the solution. And as you can see, each workshop was structured. So we started with the background, what was the background and why we are doing, and followed by the activities. So the activities were relevant to the aim to contribute towards the aim to and the outcome was related to the aim as well. And in between these workshops, we also conducted meetings with external experts who had implemented a very similar program in their setting. And there was always a asynchronous emails from the co-design members in the context of collecting feedback from them in terms of how the workshop was, what we need to consider in the second workshop based on as a process evaluation as well. So at the end of the co-design or the third co-design workshops and iterative feedback from there on, we developed an ICANN plan program. So the name of the program was also chosen by the members of the co-design team. So what is the ICANN plan program? So based on the need identified that there is a need to improve collaboration between interpreters and clinicians in ACP communication, and that there are very limited opportunities available for them to educate or for training, as well as to come together and discuss how they can improve this communication so that people from CAL backgrounds can be better engaged in the care. The ICANN plan program consisted of two components. The first component is a interprofessional education in advanced care planning for clinicians and interpreters. So it's a didactic education program. And the second component is a facilitated feedback for clinicians and interpreters during practice. So based on their practice, the co-design member said that the person, another healthcare staff who is attending the consultations with the clinicians or with the medical oncologist and the interpreters, they could give them very short feedback in terms of how their collaboration was, or how and then that would lead to the improvement in the practice. On the right-hand side, the 6 elements or the 6 topics that were to be included in the interprofessional education were also selected by the co-design members. So you can see them on the right-hand side. This manuscript is currently under publication, under review, but there is a preprint available online. So what was the implementation consideration? So in the last workshop, one of the aim was how do we implement the solution, or how do we implement the program at a local level? Because this was designed with people who represented a range of different settings and came nationally, they brought their own experience of working in a defined setting, but the program was not necessarily designed for one particular setting. So we asked them, how might we, using the how might we question, ask them what are the implementation considerations to implement this program at a particular setting, what we need to look out for if we want to implement this in a cancer service. So some of the considerations were around seeking approval from cancer service to implement the program. In the context of identifying a leader or a person who has influence over implementing a new intervention or change at the local level, and liaising with them in terms of seeking approval from the cancer service to implement the program. The other considerations were also in the context of bringing the staff who are going to be involved in delivering the program, so that we can understand what barriers they see, how this program would be implemented, and try to tackle them or modify the program accordingly to suit the need of the particular health service or cancer service. And seek for the funding opportunities if there are at a broader level. Yes. So what is happening with the ICANN plan program now? So there is a link here. So we have developed the first part, so which was the didactic education. So in association with New South Wales Healthcare Interpreter Services and Advanced Care Planning Australia, we have developed the education session, and this is the education session targeted for clinicians and interpreters who are involved in conducting ACP communications with people from culturally and linguistically diverse backgrounds. And this education is available online through YouTube, through AIHI YouTube, but it's also available as a professional development webinar for interpreters working in New South Wales. So interpreters who are working in New South Wales, they can log on to the Healthcare Interpreter Services Professional Development SharePoint site and complete this course and get the 10 points towards their PD development. We are also piloting this, the whole I Can Plan program as a feasibility and acceptability study at one cancer service. So we are conducting a pre and post intervention study at one cancer service in Victoria. And the intervention period is over the 8-week period. So this study started last week. This started this Monday, and it will go on for 31st of October. And then we will evaluate both the process of implementation as well as outcome in the context of if there was any change in the interprofessional collaboration between interpreters and clinicians. We are not anticipating that the 8 weeks there will be a significant change in how they work, but we will get some initial data, baseline data, to then take this work at a broader scale. So this was about the I Can Plan program and how we are progressing over there. So one of the elements I want to talk about very briefly is when we are involving people from culturally and linguistic diverse background in healthcare decision making, there are certain mechanisms that we can employ to improve their engagement. So when I say engagement in healthcare decision making, so this is coming out of a little bit of research scope and looking broadly from a governance perspective of a health service or cancer service, but also as a governance perspective of a research project. So when consumers are involved as members of consumer advisory group or as members of project steering group, what are the things that we can do to engage them more meaningfully in that process? So these are some of the things based on our experience, but also the 10 best practice principles we developed through a Delphi study, which was about what are the mechanisms through which consumers from CAL backgrounds can be involved in consumer engagement activities, such as being part of a consumer advisory group or being part of a safety and quality committee, etc. So these are the 10 mechanisms that the consumers makeup of should reflect the cultural and linguistic makeup of the community of interest that is being targeted as part of the process, establishing a clear purpose for engagement, and it should be agreed upon. Individual cultural and spiritual commitments or priorities are considered and respected. For example, when scheduling a meeting, so being mindful of what are the commitments, cultural and spiritual commitments as well, where they can't make to certain times, etc. So keeping those things in mind. So these are the Delphi consensus-based 10 principles, and this paper is also under review at the moment. So what are the learnings in the context of co-facilitation in co-design and implementing co-design interventions? So planning, allocating time for conduct, so especially in the co-facilitation planning, so planning ahead of how the workshops will work, funding preparatory work for the consumer co-facilitators, along with the workshop work they are participating in. Also understanding who we are involving as consumer co-facilitators in the context of consumers who are easy to access versus consumers who could be more relevant for that particular project is a consideration as well. And as Mashrika said, that co-facilitation is an art. It's a dynamic and requires adaptation, and it can vary different time. And reflective practice, and I wrote reflective practice in the context of coming back to the principles of co-design as it being a participatory action research and democratic research. So reflecting on that during the process to make sure that you align the conduct of the co-design that is reflective of the principles of the co-design as well. So reflective practice throughout the co-design to embed that. And now the second element, which was about implementing co-design interventions. So implementation consideration with co-design members. So when we are developing the intervention, trying to find out what are the implementation considerations that we should be mindful of as a researchers who are not particularly implementing or co-designing for a particular health service, trying to understand what are the things that we need to be mindful of in terms of the implementation. Gathering support from the staff at local cancer service because they are the one who are going to embrace this. So we need to understand what are the things that are important to them when we are considering implementing something in a certain setting. demonstrating need for change, so identifying why or developing a case for change, planning with all involved in the delivery of intervention, and understanding and planning with resources constraints in mind, because we don't have lots of resources. So always mindful about the resource available and how implementation needs to be mindful of that as well. So very briefly, what's happening for me as a early career researcher. So as I finished up next year, I'm starting a program of work that is looking at advancing health equity in cancer-related lymphedema as part of a Macquarie University fellowship. And for that particular project, I'm adopting or I'm using a health equity implementation framework to understand what are the disparity and develop solution with stakeholders to address the health inequity in cancer-related lymphedema. Okay. So that is for me. I'm going to stop share my slide. Thanks, Ben. I'm going to pass on to you now.
Thanks so much, Ash. And apologies, I was so keen to hear what Ash had to say that I didn't properly introduce him. So I just wanted to say thank you, first of all. I think we had dual aims of this webinar to not only showcase research with important implications for health equity in cancer care, but also to provide some practical advice around applying an implementation lens to equity research. So I think Ash did a great job of addressing both those objectives. But I just do want to properly introduce Ash before we move on to our next speaker, Dr. Nicola Creagh. So Ash is a research fellow at the Australian Institute of Health Innovation at Macquarie University, as we heard. So in addition to being an early career researcher, he's a registered physiotherapist and migrant from an LGBTQI+ background, whose work, as we heard, centres on advancing equity in patient safety and healthcare quality, particularly for culturally and linguistically diverse communities. He uses mixed methods and co-design approaches, again, as was so beautifully demonstrated, engaging directly with consumers to uncover and address systematic disparities in health outcomes. And his work's been acknowledged through multiple awards, including last year's New South Wales Premier's Awards for Cancer Research for the Early Career Researcher of the Year. So congratulations, Ash, and thanks for sharing your wisdom with us. And just a reminder to everybody that you can put your questions in the Q&A tab, and we will answer those at the end of all our presentations. And now I'll move on to introducing Nicola Creagh, who's an early career public health researcher, implementation scientist, and postdoctoral fellow at the School of Health Sciences here at the University of Sydney. And Nicola's research informs and evaluates policy and programmatic changes to optimise their equitable implementation and scale up in the Australian healthcare system. Nicola works across clinical areas, including cancer screening, cardiovascular disease prevention, and best practice hip fracture care, prioritising work that drives system changes to improve access and outcomes for populations least served by the health system. Nicola is committed to leading her research with heart and equity as core principles and feels privileged to contribute to the work of ensuring systems accessible and inclusive for all. So welcome, Nicola, and if you'd now like to share your slides, that would be great. Thank you. Awesome. We can see those beautifully.
Unmute. I need to unmute. Thank you, Ben, for the introduction, and it was really lovely. Also, I really enjoyed Dr. Ash's presentation, so thank you so much. I guess good afternoon, everyone, and thank you again for having me, and to Ben and to the Daffodil Centre. As you just heard, I'm Nicola Creagh. I'm a postdoctoral research fellow at the University of Sydney, as well as an honorary fellow at the University of Melbourne. And today I'm going to share some work that I've been really privileged to contribute to with many others as part of the NHMRC Centre for Research Excellence in Cervical Cancer Control. And so this work is part of a broader research program, which is really aimed to understand across evolutions of implementation, is equity and access to cervical screening being operationalised in Australia's National Cervical Screening Program? And if not, can it be? And so I'm going to draw across several studies conducted across different time points throughout the evolution of the implementation of self-collection in Australia. So I guess to really contextualize all of this, cervical cancer is, as I'm sure many people here know, is a cancer, unfortunately, of inequity, but it really doesn't need to be. We do have the tools to prevent cervical cancer, and these tools should and could reach everyone. So in 2020, the World Health Organization released a global strategy for the elimination of cervical cancer. And so this elimination threshold is defined as reaching 4 cases or less per 100,000 women and people with the cervix. And so the strategy calls on all countries to scale up the 90-70-90 targets. I'm not really going to go into depth on these particular targets. I guess what I want to say about the global implementation as well as the implementation in Australia is, while they are ambitious, the public health opportunity here is so significant, because scaling up the 90-70-90 targets by the year 2030 could prevent more than 74 million cases and more than 62 million deaths by the year 2120. In Australia, I think there's it's a really cervical cancer kind of policy, I think, is a really powerful and considered example of where the focus on equity is really centred strategically in policy. And this can be seen because Australia's national strategy for the elimination of centre essentially puts front and centre this kind of equity focus. So the vision of this strategy hopes for an Australia where preventable cervical cancer is a disease of the past, in which Australia's diverse communities have equitable access to information and to culturally safe and inclusive vaccination, screening and treatment. I guess to hone in on one of the kind of components of the strategy on screening, this elimination strategy in Australia does ask or has set this target that 70% of eligible people are screened every 5 years. I guess at a national level, Australia is meeting the 70% screening target, but when we just apply a population kind of statistic on or all kind of a generalization of numbers, it does hide significant disparities. So participation, unfortunately, is lower in very remote areas and among people who are living in the most socioeconomic disadvantaged areas. And these are the only 2 subgroups at a national level or a program level of which we have national data for. There are a lot of other studies, including cross-sectional and data linkage studies, which consistently show inequities for additional groups. And these inequities have been around since the very start of the National Cervical Screening Program. I guess I'm sure that there's a lot of people here today that can really understand and appreciate it and really have a personal experience with cervical screening. I guess just really quickly, what I'll say is that in Australia, cervical screening can be delivered in 2 ways. We have a clinician-collected cervical screening test where a healthcare provider performs a pelvic examination, or we also have a self-collection test, and this is where a person collects their own sample. Both of these methods, as they're tested in Australia, is equally as accurate for detecting cancer causing HPV. I guess in Australia, cervical screening is delivered by a practitioner-supported model of care, which means that the access to either one of these options really depends on whether it's being offered in during a consultation with provider. For some, clinician-collected screening is preferred. For others, self-collection offers a much more safer, more private and more acceptable option. And so to really centre the voices of people in Australia who have access self-collection. This is a person who had the opportunity to speak to a few years ago, which said it meant that I didn't have to be humiliated, embarrassed and on top of that table, and that I could do it, meaning self-collection privately, and know that I've had the test done. So I guess when the Australian Cervical Screening Program was first established in 1991, it really enjoyed really great success and substantial declines in morbidity and mortality. But after 10 years, the decline in cervical cancer incidence did plateau. And again, that persistent equities and participation have been really around since the very beginning. In December of 2017, Australia transitioned from PAP testing to HPV-based screening, which did provide the opportunity to introduce self-collection for the very first time. Initially, it was introduced in a restricted form for those who are at least 2 years overdue or had never participated in screening. And while this was one step towards expanding choice and operationalising equity within the program, really unfortunately, there was quite low uptake of self-collection. I guess, and this really low uptake of self-collection was created as a result of downstream implementation barriers that we experience in the real world. And we know this because we interviewed practitioners and screening participants. And at the time, colleagues and I really chose to engage people who had used self-collection within the program to really understand what their experiences were. It was new for the very first time. Let's talk to people who had used it and learn from them. I guess both practitioners and screening participants found self-collection and its availability in Australia to be really, really wonderful, but offering it was difficult, and offering it was really difficult because of this restricted eligibility criteria. One GP described this frustration to say that this frustration was the time that it takes to ensure that they meet the eligibility criteria. And then when you do, boom, you get a call and no, you can't because they're not due for a few days. So I guess this like inability of being flexible, or the program being inflexible, really created some challenges in terms of operationalizing equity within the real world. I guess then in 2022, the program evolved again, and this time the change was to expand access to self-collection. And so the updated cervical screening guidelines now makes it really clear that anyone who is eligible for cervical screening should be offered the choice between vaginal self-collection sample or a clinician-collected sample. Again, really to reiterate, because of this practitioner model of care, for the choice between screening modality to be experienced by people, this delivery of the choice really needs to be adopted and delivered by cervical screening providers, and this really largely occurs within primary care. Now, this program change, made possible because of policy and guideline change, does have the real potential to increase equity and access to cervical screening. But on the question of whether this choice is being operationalised in routine clinical practice, I guess for myself and I'm sure many other people, I think this is a really interesting question. And so what I'm showing here right now is publicly available MBS billing data on the use of self-collection 2 years after it was expanded or universal access to self-collection became in. And what we can see is a variation on its use. We don't know if the 28 percentage point difference between the ACT and Tasmania actually reflects whether women or people with the cervix in the ACT are choosing more clinician-collected screening, and in Tasmania they're choosing more self-collection. But based solely on the data, what we also don't know is if this variation is a signal on whether there is inequity in access to self-collection in our current healthcare system. And if so, would this limit the ability of self-collection to increase equity and participation and kind of those outcomes that we really, really want? So I guess to explore this in part, if and how universal access was being implemented in practice, I'm going to talk relatively quickly across 3 different studies by different people. And so the first study was another qualitative study conducted 7 to 12 months after policy change to universal access. And this time we spoke to cervical screening providers, regardless of whether they were offering self-collection or not, to really understand what influenced their decision making. In this particular study, we used the COM-B framework, which is an implementation science model that helps unpack the capability, opportunity, and motivation drivers of behaviour. And so it was this framework that really guided our exploration of what enabled or limited practitioners in real-world settings. I guess most of the practitioners that we got to speak to really expressed really strong support for expanding access to self-collection. Many saw it as a really meaningful way to engage or to increase opportunities for people to engage in the national program, particularly for people who might not otherwise want to do cervical screening if self-collection was available. So one GP summarised, I think it's sort of giving those women a choice, and it's definitely increased the uptake of screening screening program, because otherwise, whether they're shy around it or they have trauma around it, meaning clinician-collected screening, is just not something that they're comfortable with. One thing in this study that was made really clear is that all practitioners were really motivated to provide high quality patient-centered cervical screening. But for some, this was conceptualized as offering clinician-collected screening because clinician-collected screening involved a more thorough provider-performed pelvic examination. One nurse explained that we've had a couple of patients who've come asking to do a self-collect, and that is on the back of them receiving a letter. But the conversation I've had with the patient was along the lines of, when you're next due, it'd be beneficial to consider a proper pelvic examination. Another study led by Anna Colling and Dr. Tessa Saunders used the Ottawa Decision Support Framework to explore whether screening participants in the first 2 years after policy change who had done cervical screening, irrespective of their screening mortality, were offered a choice between self-collection and clinician-collected screening. And again, in this qualitative study, fewer than half of the 46 people interviewed recalled being offered the choice. One participant said that I did ask if I'm eligible for self-collection, and she made it very clear that self-collection is not as accurate because people can't get to their cervix, and it's always better just to come into the clinic. So I just went with it. Another study that that I'm going to just quickly speak to now is this, which is actually part of an interrupted time series, which is a natural experiment. It's some implementation scientists definitely say it's very useful to evaluate kind of real world kind of changes when RCTs are not practical nor feasible. And so in this interrupted time series, we described as one aim the proportion of cervical screening collection types across 69 general practices in Victoria. And we used de-identified data from patron data for decisions repository at the University of Melbourne. I guess the benefit of this data set compared to publicly available MBS billing data I showed earlier is that this data allows us to observe how self-collection is being used at the point of care within the practices where screening is actually delivered. And so compared to metropolitan practices, regional and rural practices show a greater increase in the first 12 months after policy change in the estimated proportion of self-collection tests. And so by June 2023, that was 12 months after change, they did have a higher estimated proportion of self-collection overall, or at the final month, should I say. And so I think this is a really positive sign, because if we remember earlier, one of the subgroups that I was talking to about that does have lower participation is people who live more rurally. So I guess one potential explanation of this variation between metro and rural practices, although really important to highlight that the qualitative studies I've spoken to you about and this quantitative study are not interconnected, but this variation in practitioners' perceptions of self-collection, particularly around its suitability and feasibility, may have influenced the variation in its use between metro and rural practices. I guess this raises, I think, an interesting or an important question. Can equity in Australia's program be fully operationalised if the delivery model is fixed and rigid to one model of care? One thing I don't fully have time to engage in right now in this talk, but I know is very much present in our health system and in present very likely in everyone's minds, is that there are real and significant barriers to access of general practice or to the health system at large, including the impacts of the systems of oppression that impact the determinants of health, of the social determinants of health, and the way that people live, work, and be well. And so this brings me to the final part of my talk about looking into the future. And while this isn't a formal program change like the previous two, a team led by Associate Professors Claire Nightingale and Megan Smith are now really exploring whether flexible models of cervical screening could be considered and implemented in Australia. And part of that Futures Focus work led by Claire Bavor and Dr. Tessa Saunders has, through lots of stakeholder consultations, shown quite strong interest in more flexible models of cervical screening. And these includes options like receiving a self-collect kit in the mail, picking one up at the pharmacy, or having a telehealth appointment and having one sent out These models potentially might offer really promising ways to extend reach and reduce barriers, and they represent a potential pathway to further operationalise equity more fully within the current program. There are many practical barriers that people are working through and that would need to be worked through, like roles, responsibilities, and logistics, confirming eligibility of screening, and what would happen around follow-up. I guess watch this space or actually watch their space about how this might evolve, I think is really interesting. And the way in which groups and people are using implementation kind of research across evolutions of programs to really look at and consider equity and its operationalization. So I guess to bring this all together, and what I hope I've tried to communicate today is that across these three models or potential models is that policy change or something in the outer system might alone not be enough to fully operationalize equity in real world systems so it's felt, experienced and lived by the people who would benefit from that equity. And so the restricted access model showed us that really rigid eligibility created quite significant downstream implementation challenges. The universal access model expanded choice, but in practice, the choice or receiving this choice really is dependent on kind of other actors in the system. And now there is some growing support of flexible models, and how these models do come with practical considerations that might need to be worked through, but people are, and that's maybe the power of implementation research. And so I guess the last thing that I'll say that is probably a thing that kind of keeps me up at night, and I guess I'm working through as I evolve throughout my career, is this idea is if equity is to be operationalized in existing programs, it might require systems that are flexible around the realities of current clinical practice and around the current kind of realities of our healthcare system and our society at large. So I thank you very much. And again, I'd just like to really acknowledge all the all colleagues and all the people that I've named or that have been on the screen today, because work is really a collective. So thank you very much.
Thank you, Nicola. Yeah, for a lovely overview of, I guess, the different implementation barriers at different levels to self-collection in this instance, and cervical cancer screening, and some strategies that you've kind of developed to overcome those. I think, yeah, that the whole adaptation and flexibility piece is something that, is something a lot of people are grappling with in terms of how can we still deliver something that's evidence-based, but also, meets the realities of messy kind of clinical practice in the real world. So it's great that we've got very clever folks like you thinking about that issue. So thank you very much. As I said, just a reminder to everybody that just to put any questions for Nicola or Ash in the Q&A box. I'm now gonna, unfortunately, our final presenter, Dr. Verena, couldn't be here in person today, but I am going to share her presentation, which she's pre-recorded, and we'll have some questions in 15 minutes time once that's done. So hopefully you can all see and hear that.
I'm a research fellow at the Daffodil Centre. I'm excited to present our work on adapting a fear of cancer occurrence clinical pathway for Chinese-speaking people with cancer. My apologies for not being able to present this live, but I hope that I'll be able to share some helpful insights as to how we aimed to embed equity throughout the various stages of our project. Before I continue, I would like to acknowledge the traditional owners of the lands from where we are joining this webinar. For me, at the time of recording, that is the Gadigal people of the Eora Nation. I would also like to pay my respects to elders past, present and emerging, and I extend that respect to any Aboriginal and Torres Strait Islander people attending today. Australia is one of the most culturally and linguistically diverse countries in the world, where about 28% of people were born overseas, and Chinese languages are among the most commonly spoken. Up to 67% of people from multicultural backgrounds experience fear of cancer recurrence, where if left unaddressed, this can persist for many years and result in poorer mental health and greater healthcare usage. Even though there are effective interventions to address fear of cancer recurrence, there are barriers to implementation, including the lack of a clear referral pathway. So in order to address this gap, our team recently developed a clinical pathway that aims to assist healthcare professionals with identifying and managing fear of cancer recurrence. So the clinical pathway was developed with the input of about 100 Australian healthcare professionals and researchers. The pathway consists of 4 key steps, which include screening, assessment, stepped care, and reassessment. If you'd like to know more, please feel free to read our publication there. So this brings me to our current project that my team is conducting. We are doing a qualitative study that aims to identify the cultural barriers and enablers to equitable implementation of the clinical pathway. We are consulting with multiple groups, which involves semi-structured interviews and focus groups with people who are cancer survivors, caregivers, healthcare professionals, and community stakeholders, such as hospital interpreters and community support workers. For the patient and caregiver focus groups, these were conducted in Mandarin and Cantonese, facilitated by our bilingual RA. So this will allow us to explore views about optimal implementation of screening, assessment, and stepped care. Our work is underpinned by the Health Equity Implementation Framework. So this is a combination of 2 existing frameworks, the IPA-REIS and Healthcare Disparities Framework. And the strength of this is that it is specific to the healthcare setting and explains factors relevant to implementation and disparities in healthcare at multiple levels. So there are 5 key domains, which include characteristics of the innovation, in this case, it's the clinical pathway, the clinical encounter between the patient and provider, culturally relevant factors of pathway recipients, in which case it's the patients, inner and outer contexts, such as clinics and the healthcare system, and societal context. So a key strength of our research project is our partnership with Can Revive. They are a support organisation for Chinese-speaking patients and families affected by cancer. They have several centres that span across areas that have a high population of people from Chinese backgrounds. So today I'll be sharing our journey about how we work together to conceptualise the study, including considerations around recruitment, consent, and data collection. Also, in the interest of time, I'll only be focusing on our processes relevant for patient and caregivers. I wanted to give a quick shout out to our wonderful team. This project would not be possible without the involvement and input of everyone on the team. I particularly want to acknowledge and thank Can Revive and Eric Hill for their partnership in our research, and also to Sydney Health Partners who are funding this project. So it was important for us to ensure that the discussion guide that we use for the interviews and focus groups reflected both the Health Equity Implementation Framework domains, and that it also takes into account cultural considerations related to discussing fear of cancer recurrence. So our partnership with Can Revive here played a key role in helping us review the questions to ensure that the topics discussed actually reflected what the community needs. So several considerations were raised throughout our discussions and meetings, but I'll just highlight the 2 key points. So the first is the importance of considering the different communication preferences of patients. across several stages of the clinical pathway. So, for example, with screening, patients may feel more comfortable discussing this with their GP rather than an oncologist due to the existing rapport and the GP speaking the same language as the patient. So based on this, we ended up including an open-ended question about who patients prefer to have these conversations about fear of cancer recurrence with. And the second consideration was the impact of cultural taboos surrounding discussion of fear of cancer recurrence and emotions generally, particularly around family, where people from Chinese backgrounds may wish to protect their family members by not talking openly about their stress and burdening them. So as such, we included another question in the discussion guide about whether patients preferred to have these discussions with their family members present. We also had to make sure that the language of the study materials were appropriate. So we performed translations and back translations to ensure that the language was appropriate and suitable for the community that we were trying to recruit. So one key consideration is that the Chinese community is not one homogenous group. We also needed to think about the Chinese diaspora and variations in dialects. So different terms can be expressed in different ways. This can be extremely difficult to accommodate from a research planning perspective, particularly when you've got limited resources and funding for the different translations. So, for example, we came across several terms for caregiver, and there was uncertainty as to which term was more appropriate to use. So to overcome this, we consulted existing resources, including ones offered by CanRevive, which then guided the terminology that we used. We also kept an internal glossary for our bilingual RA, where if potential participants were unsure, there was the opportunity to further clarify this with them using a term that they were more familiar with. So following translations and back translations, CanRevive volunteers helped check our final discussion guide, and they helped make edits to improve the clarity of our questions. So recruiting people from multicultural backgrounds in research can be challenging, particularly if there's mistrust or an absence of rapport with the research team. So again, having conversations with CanRevive about appropriate recruitment approaches was essential. And one of the feedback that we received from CanRevive in our recruitment planning meeting was that experiences can differ depending on people's socioeconomic background and where they reside, which can affect the kind of responses that we get from people. So, and the other consideration that was raised was that some patients that attended CanRevive were actually unaware what stage their diagnosis was, which had implications for our study advertisement flyer, where people may be unsure if they're eligible or not. So to overcome these challenges, we recruited across different CanRevive centres to capture participants from different locations and socioeconomic backgrounds. And we also made sure that our translated materials had really clear messaging about the inclusion criteria. So for example, just simply saying completed treatment in the past 10 years. We all know that informed consent is crucial for ensuring that people understand what the research involves. So this goes beyond mere translation of the information sheet and consent form. Based on past research projects, we found that despite providing translated materials, participants were still unsure why they had to complete a consent form, And some were worried that this meant they were committing to something beyond the research project. So to overcome this, we provided participants in the current study with the opportunity to discuss this verbally with the bilingual RA first. And if they felt more comfortable meeting in person at Can Revive, then they were able to do so. So this provided participants with the opportunity to have a conversation with our RA about participation and to have any of their questions answered and addressed. And we also provided the option to undergo verbal consent for those who preferred this method and were unable to complete the online Qualtrics consent form. I'm excited to share that since then, we have successfully conducted 3 focus groups across 3 Can Revive centres. And it was observed in one of the groups that some people had mentioned in passing conversation before the focus group had started that they had experienced fear of cancer recurrence. However, when the focus group started, they responded having no concerns when asked directly if they had any fear of cancer recurrence. So this raised the question as to whether being in a focus group might have influenced people's willingness to share with the research team. And with this potential power imbalance in mind, we discussed strategies for overcoming this in the next focus group. So one of which is to balance between direct and indirect questioning. This does involve a bit of judgment from the facilitator, where if they sense that some people might not feel comfortable sharing about themselves, then we can ask an indirect question. So for example, instead of saying, do you have fear of cancer recurrence, we could frame this as, how often do you think Chinese background people worry about cancer returning? It was also discussed by Can Revive that perhaps a less formal setting as well might be able to address that power imbalance as well, such as a casual afternoon tea, where people feel more comfortable sharing and they get to guide the topics that they discuss as well. So this brings me to our current progress. I'm very happy to share that we have met our recruitment target for all groups, with the final interview scheduled for later this month. So the next step is data analysis. So we will be using directed content analysis guided by the health equity implementation framework domains. And even though we haven't started data analysis yet, I would like to leave you all with some brief insights into the feedback that we have received so far. So barriers to pathway implementation across the components included patient reluctance to discuss their emotions with their doctor, questionnaires about fear of cancer recurrence not adequately capturing their actual experience, and unwillingness to engage with a psychologist. So some of the facilitators shared by participants included adjusting the healthcare professionals' communication strategies, such as repeating the question in different ways or reframing it, complementing the questionnaire with further conversation to better understand the impact that the fear is having on the patient's life, and to also provide translated information about available support options and services and how to actually access them. So that's all the time I have for now. Thank you all so much, and please feel free to email me if you have any questions or if you simply would like to know more. Thank you.
Right. Thanks to Verena for providing an update on that study in progress, which I guess echoes some of what Ash talked about in terms of the flexible approaches needed to overcome power imbalances and engage with culturally and linguistically diverse communities. So we've now got about 15 minutes for questions. I'll ask Nicola and Ash to turn their cameras back on. to join in the discussion. Just a good time to remind you all, the easiest way for us to do this is for you to put your questions in the Q&A box. Otherwise, if you can also raise your hand and I can unmute you if you prefer that, although it's a little bit trickier for a technologically challenged person like me. But yeah, so any questions, pop them in the Q&A box. I might ask one just to get the ball rolling, but yeah, we couldn't have a webinar on implementation science without talking about frameworks. We've had a couple mentioned in the various presentations. Ash, you mentioned theoretical domains framework, and Nicola used the COM-B model, both of which kind of, in my understanding, are fairly focused on individuals. And you touched on a little bit in some of your comments, Nicola. Do you feel like you got a sense of all those frameworks kind of sufficiently allow you to look at barriers at a more systemic or structural level? And do you have any thoughts about how you can combine use of those frameworks with other ones, perhaps to get at those more readily?
Yeah, thanks, Ben, for the question, and Ash, jump in at any point if you have thoughts. I guess because I've been actively thinking about this myself, and you kind of lean into the implementation science literature, and what they say about kind of outer systems and frameworks, and there is a sentiment, and I think it's been measured that a lot of the frameworks is, like you said, looking at kind of organizational level or individual level barriers. But I guess sometimes our impacts, or the extent to which equity can be felt and experienced in real world systems is because of all the outer system things. I don't know if I have a kind of clear-cut answer. I think I'm learning. I'm trying to learn how to take more weight on what happens beyond the kind of organizational level things, and I am kind of leaning into kind of the policy kind of theories and the policy frameworks that have traditionally, until very recently, sat more kind of outside of, or typically outside of, the domains of implementation science, although there's some scientists overseas that are trying to get that back in. But there is by Bollock, it's the kind of policy implementation science kind of framework. I can put it in the chat. I haven't used it yet, but that one seems to be thinking about implementation process in the context of what is happening on the outside. So I'll chuck it in, and if anybody wants to sit down and chat about that particular framework, I'd love to, because I'm learning about it. I guess that's my response to you, Ben.
Thanks, Nicola. And Ash, do you feel like I mean, you're particularly interested in culturally and linguistically diverse people. Do you feel like that frameworks like the TDF kind of capture those broader cultural influences? Or
So with the theoretical domains framework, we did identify, but again, I think as Nicola said, it was more at the organizational level or service level rather than the system factors. So we did identify in the context of the I Can Care Plan project about the knowledge of the cultural factors and the opportunities available at service level or at I suppose that when you are at the health system in training level, to understand what are the cultural factors that may impact participating or engaging with people from CAL backgrounds in ACP communication. But I suppose the framework that Nicola mentioned, I will have to look at that as well. But the HEIF framework, I haven't used it yet, the Health Equity Implementation Framework that Verena touched upon and introduced. So I will be very keen, because it does have some elements in the context of health equity at systemic level elements as well. So looking at the environmental context or looking at the outer context, that the diagram that Verena shared. which was in my presentation as well, but she talked about it. So I think when I start my project, and I would be very mindful of considering that. Yes.
Thanks, Ash. Let's have a look in the Q&A. Oh, thanks for posting that in the chat, Nicola. I will also have to have a look at that. In your talk, you identified some of the provider beliefs around the kind of efficacy or the comprehensiveness of self-collection screening not being quite as good as a provider-led examination, and your solution or your team solution seems to be to kind of work around that by creating more flexible models where you don't require a provider to I guess be the gatekeeper to that system in some way. What can you talk us through the considerations you go through when you're choosing whether to kind of take on a barrier like that head on, or whether to kind of create more of a workaround that bypasses a barrier? Like, why did you choose not to do clinician education about the equal kind of efficacy of those two screening methods?
Yeah, thanks, Ben. I think that's a really good question. I'm gonna try and attempt to tackle it on its head somewhat. I think I'll start by saying that the things that I have reflected on towards the late stage of my PhD is when we're thinking about kind of the context, the out of system context of general practice. You've got lots, like it is one of the mainstays of the Australian healthcare system. General practice is funded in a very different ways. We've got primary health networks, but getting into the guidelines are a really great way, but then we lean into kind of other kind of guideline literature and what we're saying, what I'm trying to say is there isn't one size fits all model. And we know that from implementation strategies, right? We can look at audit and feedback, and we can look at education, and lots of them improve, but it doesn't, we're never going to have 100% kind of change just because we do one thing. And I think that in the program, I haven't touched on this, I didn't have time to touch on this today, but the program, over the time of which I've been really privileged to kind of be involved in kind of implementation research alongside of the program, they have done all of this. There have been extensive webinars, and the leadership of Australian Centre for Prevention of Cervical Cancer and the program itself and state departments, there has been massive amounts of work to really lead into program change. Such large scale change at a whole of system level is really challenging. And so I think the flexible models work being led by Associate Professors Claire Nightingale and Megan Smith and many others are leaning into the fact that it's not one size fits all. And so we can do practitioner supported, because there's lots of benefits of doing that. As well, we might think about complementing additional things. So like why we wouldn't just do one strategy, why should one implementation strategy, why should we just do one model of care? I think that's their focus, and I really celebrate them. I hope I've answered your question.
Yeah, no, I think that's great, Nicola, to reiterate that one size fits all is never gonna kind of do everything that or meet all needs for all people. Ash, there's one question in there that's kind of, I guess, was more targeted for Verena, but maybe you can share your thoughts on it. And it relates to another question that is relevant for you, Nicola, but you might have already answered to some degree. But Ash, you work with culturally and linguistically diverse people. There's obviously a lot of variation, like, between people and even within certain cultures, as Kate Dunlop highlights for the Chinese community. How do we accommodate that diversity when it comes to implementation, given what we've just heard Nicola say about, one size doesn't tend to fit all?
I think there has been very similar title to what Nicola says, one size doesn't fit all. There was a policy paper in the context of people from culturally and linguistically diverse background in terms of uh, aggregating them as a group. And so I think being mindful, obviously, of what are their individual needs, preferences, or what are their individual considerations is always helpful in the context of implementation. So, for example, the education that we developed as part of the ICANN plan program. So that education is targeted for clinicians and interpreters. And one of the topic within that education is managing expectations or cultural expectations of people from CALD backgrounds during ACP communication. And in that education, the online education, the educators have highlighted that stereotyping one community, that one community has this view, doesn't mean that another person from that particular community will fit into that view, or they have the same view in relation to ACP advanced care planning, how that happens, or their end of life wishes. So it is important in the context of being mindful that there are specific mechanisms required to engage people from culturally and linguistically diverse background, but that is not that they all have the same needs or requirements. So there is that responsiveness of cancer service or cancer clinicians or healthcare providers in terms of how they respond to the diversity, but then also acknowledging that people are different. So having that in the context of delivering a person-centered care, that is important that we identify for individual preferences, wishes, or what their needs are. But at a broader level, we understand that there are specific mechanisms required for a system or a clinician to be responsive to then identify what are those individual wishes, preferences, care needs, etc.
Yeah. I guess what I love about some of your work, Ash, is you've developed these broad principles, I guess, to guide implementation in practice. But I guess what I'm hearing you saying now is we have to be flexible in how we apply them and take that person-centered approach when we get to that point. People have taken a while to warm up, but now we have lots of questions coming through that I'm probably not going to, we have a minute left, so I'm sorry, we're probably not going to get to addressing those, but thanks for those comments. Eleanor, I can probably connect you with Nicola to talk more about that if you want to learn more about the COM-B model. There's some great work happening that Caitlin in cervical screening for people with intellectual impairment that Caitlin's highlighted. It would be interesting to see how much overlap there was, and Alan White's highlighted some of the, I guess, overlap with PSA testing in the prostate cancer space. But thanks everyone for your comments and questions. Thanks to Nicola, Ash, and Verena for 3 great presentations, and thanks everyone for attending. Just a reminder that when this ends in a minute's time, hopefully you'll get a quick survey that will pop up that you can complete. We'd love to get your feedback. And I guess just to reiterate, Ash and Nicola, that there's some comments in the Q&A as well, just saying thanking you for your presentations. Really appreciate your time and expertise, and I hope to see more of you at the next Daffodil Centre webinar. So thanks everyone, and have a great afternoon.